Our final speaker for the day is Dr. Elizabeth Diekroger, having completed her fellowship in developmental pediatrics at Rainbow Babies and Children's Hospital. She currently serves as an attending in the developmental behavioral peds department. She's board certified in pediatrics and developmental pediatrics. She has a professional membership to the Academic Pediatric Association, the Society for Developmental Behavioral Pediatrics, American Academy of Pediatrics. She has been named a Research Symposium Scholar for the Society for Development and Behavioral Pediatrics, and is the recipient of multiple grants, as well as has authored multiple presentations and publications. Please welcome Dr. Diekroger. Thank you.
So I said there is great irony in the fact that the last presentation of the day on a Friday afternoon is about ADHD. So if you at this point in time are suffering from conference-induced ADHD, please feel free to caffeinate yourself, to go to the bathroom, stand up and stretch. I will not be offended. I understand. Next order of business, just to talk briefly, so things to talk about today. We're going to talk about, this is more of an kind of ADHD 102 kind of, less opposed to ADHD 101. I think a lot of people have heard, like, these are criteria, here's the Vanderbilt, here are stimulant medications. So this is meant to be a little bit, okay, you know, so you have that information, how to kind of sort out ADHD when things are a little bit cloudy, tools might be helpful, what are some of the pitfalls of those tools, and how can you identify those to help you use them better. What differences between some of the different ADHD medications. We're still really going to stick to the stimulant category because those are really far the most effective, but I think tailoring them to your patient's needs can really help, you know, more effective treatment regimen. And then the last thing we'll talk about is managing stimulant side effects. I have no relevant conflicts of interest to disclose. We will be discussing pediatric psychopharmacology, which often ends up running into the off-label realm. There's nothing physically in the presentation that's off-label, but depending on what questions are asked, we may go in that direction. So I will let you know if we do, but just to disclose that up front. So before we start, I don't know if any of you have used today's Meet before. Anybody done that? Essentially an online platform. If you go to this website, we will have a little discussion forum. So I'm going to have it pulled up on my computer also. So as we're going through each section, if people have questions, you can type them in real time. You may notice this already, but I'm a little bit of a nervous speaker, don't like to speak in public. So if any of you are like that and would prefer not to raise your hand, you can type a question to me, and I will review the questions when we get to the end of each section. I have a minute to pull that up, and I will pull that up on my computer as well. All right, sort it out. So to start off, let's talk a little bit about the history of ADHD. So I think a lot of people think of ADHD as, you know, a modern world. And while I think in many ways the prevalence has become more well known, it's been much more identified, much more common in the kind of modern environment. This has been an issue for a long time. So this apparently George Sand was wrote stories that were very popular in the United States before before the Civil War. And so one of his characters in his stories was Sylvain. And so if you read about Sylvain here, he is running in front of cattle. He is frequently falling in ditches. We can all agree that Sylvain is probably suffering from ADHD. And not only is that what's going on, but it's creating a lot of problems, even in 1851. There are also references in German literature way back into the 1600s, and some people even contend that there are some references in Greek poetry, but I haven't read those myself, so I can't speak to that. ADHD has changed quite a bit over time. So it was originally classified in what we know today as ADHD from kid encephalitis as a complication of the flu pandemic during World War I. A lot of them were kind of collected into these boys' homes that were, I don't know, somewhere, not juvenile detention, but somewhere to kind of help straighten them out. And in that time, they had tried a medication on them that was used to try and help keep soldiers alert during the war, and they found that it actually helped some of their behavior. So this was originally described as minimal brain dysfunction or minimal cerebral dysfunction as a complication of encephalitis. You see through the years, the name has changed quite a bit. If you hear the term ADD thrown out, so it doesn't mean that you have ADHD without hyperactivity. It's actually just the term from a former version of the DSM. So if these days the correct term is ADHD, and you could specify whether it's primarily hyperactive, primarily inattentive, or combined. They have changed the name or any of the subtypes in the DSM-5. However, at this point, if you go through and read DSM-5, they kind of de-emphasize trying to classify people as one subtype or another, because some of the natural history of ADHD is that you actually lose the hyperactive symptoms over time, although the inattentive and impulsive symptoms tend to remain. So especially as DSM-5 was focusing more on identifying adults and adolescents, that they have kind of de-emphasized trying to sort them into a specific category, because when they're older, that may not be possible. So I think it's helpful when you're talking to families or professionals or anyone about ADHD to have a good explanation of how it works. So I will tell you a little bit about how I explain it to families. So if that is helpful in your practice, feel free to use it and pass it on. So there is some contention about the main issue in ADHD. So some people are very partial to, like, this is primarily a movement issue. It's a basal ganglia issue. But most people agree that at least there is some dysfunction in the prefrontal cortex. So that prefrontal cortex is kind of the very front of your brain. And that's when people talk about the brain maturing late, that's the part of your brain they're talking about. So, 20-year-olds who have immature brains, it's that prefrontal cortex that is not quite mature yet. And ADHD, that prefrontal cortex is not working quite as efficiently or effectively as we would like it to be. So this kid, if he has ADHD, he's like, hey, I should go jump on the bed. That's really fun. And so he goes and jumps on the bed before his prefrontal cortex is like, hey, maybe that's a bad idea. Last time that you fell off, you got stitches. That was really a bad time. Don't do it. And so that prefrontal cortex really isn't policing your reward center in the way that it's supposed to. And also then there's dysfunction with planning and kind of, thinking long term. So this is another slide to kind of illustrate that where the frontal cortex is, but also that you can see in these images, these are looking at myelination and brain maturity, that prefrontal cortex really is kind of maturing on the later side. There are some studies that show that in ADHD, kids who have a diagnosis of ADHD versus kids who do not have a diagnosis of ADHD, that on average their prefrontal cortex is maturing approximately 2 years later on average. So, some of those kids, you can imagine that, so outcomes of ADHD, that a third of kids we think is probably going to have minimal symptoms as an adult, a third go on to have present but manageable symptoms, and a third go on to continue to require medication, that, some of those kids who are just late maturers probably fall into that first category. Curing ADHD, what it is that people have with trying to explain it to families before we move on to diagnose ADHD. I will move on. If people think them, we can certainly address them at the end. one of the next big questions that comes up when we're trying to identify ADHD is really how common is it? So the most recent CDC data from 2016 shows actually a drop in reported prevalence of ADHD. So this is previously, I'm going to get the number wrong, it was somewhere 11-something percent, 11-point-something percent. And so this is a phone and actually online survey that the CDC sends out, and they used to do in all the surveys until this one was they would call people and they'd say, hey, we're doing this survey, are there children in your household, are you willing to participate? And I would ask them this laundry list of questions, and when they would get to ADHD, they would say, has a medical professional ever told you that your child has been diagnosed with ADHD, or that your child has a diagnosis of ADHD? And they would have to say yes or no, and they'd say, have they ever received treatment? What kind of treatment have they received? And so we think that probably this survey may overestimate a little bit. So, if the teacher says, oh, he probably has ADHD, or we think that probably people, even though the question says healthcare professional, that probably people are identifying other professionals who have told them that their child may have ADHD as having given them a diagnosis of ADHD. You compare in the U.S. to kind of from around the world, our rates are much higher. People who spend a lot of time talking about ADHD, we think probably 6-ish% is an accurate rate for kids. A lot of this is very culture dependent. So if you have a culture where high activity is really getting in the way of what you need to do, you're going to have a smaller percentage of kids who look like Sylvain, who is running in front of the cattle, and you have kids who have trouble paying attention in math class. So that is very cultural, based on what the expectations are, what the needs are in your culture, what your typical day-to-day routine looks like. So it's difficult to differentiate risk factors for having been diagnosed with ADHD for true risk factors for having ADHD itself, as the diagnosis process, as you know, is a little bit murky. And it is done very differently in different places. There's some places where you can walk to the doctor's office and say, hey, I think my kid might have ADHD, and you can walk out with a diagnosis of ADHD and stimulants. Whereas if you walk into my office, I'm going to run you through a very extensive evaluation, and if I'm not sure that you have ADHD, I may not give you a diagnosis right away. And it's that decision ends up being very complicated by the immediacy of the need. So if you have a kid who's doing dangerous things, you may be more likely to make a diagnosis or start treatment than if you have a kid who's just struggling a little bit in school. But in the epidemiological studies, these are all factors that tend to be associated with receiving a diagnosis of ADHD. So once again, a lot of this is pulled from some of that CDC data. Things to think about for our work in pediatrics. So anything that prefrontal cortex seems to be very sensitive to any kind of disturbance to the brain. So anything that may have some sort of negative effect on the brain is going to affect your rate of ADHD. So premature preemies, anyone with GI, anyone who's had any kind of toxin exposure, whether it's a prenatal exposure, whether it's lead, if you have low birth weight. And actually I didn't put seizures on here, but having a seizure disorder is actually a huge risk factor for having ADHD. Think about when making an ADHD diagnosis. So ADHD is really just ADHD by itself. Depending on which numbers you look at, somewhere around 2/3 to 85% of kids will have some sort of identifiable coexisting condition. Probably number one on that list is a learning disability of some sort, so dyslexia, dyscalculia, dysgraphia, something in that realm, or some combination of those. Language disorders are extremely common, whether that's ranging from an articulation disorder to a language processing disorder, where a child is having difficulties processing language in real time and then producing meaningful answers to things that are told to them. You can imagine how that might look like ADHD in school, or how that might complicate ADHD. Anxiety is very, very common in kids with ADHD. So somewhere around 30% of kids with ADHD have a coexisting anxiety disorder, and somewhere around 30% of kids with anxiety also have coexisting ADHD. You look at the numbers actually looking for anxiety in children. The anxiety numbers are actually much higher than the ADHD numbers. So this is kind of one of my soapboxes is, be on the lookout for anxiety, because in young kids it can look a lot like ADHD, and we'll talk about that a little later. I think people think a lot about the externalizing disorders, so ODD and conduct disorder, sleep disorders, and the other that enters my world a lot would be kids with autism. And there's actually one paper that looked at a referred sample of kids who came to the BP Center and how many of them had a diagnosis of ADHD and then they went to get a diagnosis of autism, and that ADHD diagnosis was perhaps not accurate. It looked like ADHD, but really when you kind of dug down, it was actually autism. And the reason they weren't attending was because they were missing social cues to attend in that situation. So this is just, for those of you who are visual learners out there, this is the information that was on the previous slide, but present in graphic form. This chart is for you guys to refer to later, but I'll talk through it a little bit. So I made this for a presentation I give the residents on identifying and treating ADHD, and it's to help you sort out those common presenting symptoms and what disorder you might be dealing with. This is mostly based on how children present with the DSM criteria of the different disorders. So, the most common symptoms I see in my practice are inattention, social impairments, and hyperactivity. I put sensory symptoms in there because that gets so it's very similar across groups. So I think kids who have sensory symptoms are very common in ADHD, autism, and anxiety. It's hard to tease out which of those I have based on that. So looking at to have inattention. So in ADHD, this is kind of that poor executive function. So that prefrontal cortex isn't reminding you like it's supposed to. Hey, you're supposed to be doing your math paper right now. Hey, you're supposed to be doing your math paper right now. I know that's an interesting sound out there. You're doing your math paper. That's kind of the process of why these kids are inattentive. Kids with autism, inattention is more linked to their difficulty reading social cues in different situations. And for very severely affected kids, they may not have the interest or motivation to attend to other people. They may be very interested in what is into them, and that, especially in young children, that kind of idea of other both needs and other people trying to get them to do something isn't prominent on their mind. Kids who are anxious. So I end up having to ask my young patients what's distracting them in school. I tend to give them examples. So my anxious kids tend to be distracted by something that's going inside their mind, right? It's an internalizing disorder. It's all going on the inside. And so unless you ask them, you're not going to find out that the reason that they're having trouble paying attention in school is that one day they miss the bus, and so now their parents have a phobia of missing the bus, and so they cannot pay attention at all afternoon because they are so fixated on the fact that they might miss the bus. So you really have to ask kids, it sounds like you're having trouble. What you need to do in the afternoon at school, what's going on? What's happening? Tell me what's happening. Sometimes I give them an example. Some kids come into my office and, they tell me that they're having trouble paying attention in school because there's so many other things going on. They can hear what's going on outside. Somebody else might be having recess, and that sounds really interesting. And they found this really interesting, loop on the carpet, and that might be, they want to check that out. And there's just so many other things going on that they want to check out in the classroom that it's hard for them to do their work. This kid, you say, so some kids tell me that they have trouble paying attention in school because there's lots of things that they're thinking about. So they're thinking about, what might be happening next, or they might be thinking about whether did they remember to turn their homework in, or they might be thinking about, they're trying to do their paper, but they're worried that maybe they didn't answer the last question correctly, and so they're having trouble moving on. Does either of these sound like you? Give them the choice for both of these sound like me, neither of these sound like me, because there's definitely kids with other issues going on. Looking at that social piece, I'll just talk about the kids with ADHD briefly. So if you can imagine a kid with ADHD who's, maybe 6 and trying to play with other kids on the playground, they're like, hey, let's go play kickball. And, you know, the ADHD kid is like, great, I love kickball. And then, you know, he sees something else going somewhere else, and he's done before the kickball game even gets going. So he doesn't have a chance to build those skills, learn to interact with the other kids. And so especially younger kids with ADHD can look fairly socially impaired. And older kids, lessons can be very inappropriate. So they have their attention and impulsivity often brings them to do very inappropriate things with their peers. We had one we were talking about in our office the other day who he really wants people to like him, but he doesn't have a lot of good experience with his peers because he didn't have that time when he was younger doing things with his peers. And so his for how he's going to get everybody to like him is to tell really inappropriate jokes. So he very impulsively tells really inappropriate jokes in really bad settings for inappropriate jokes. And so this just kind of snowballs his social impairment related to his ADHD. The last thing we'll talk about is the hyperactivity. So with ADHD, the classic description is that they feel like they need to move, like they're being driven by a motor. So, you know, these are those kids that are the little ping pong balls in your office. You probably don't get as many of those as I do, but everything in our office is bolted down because this is what I do. So, you know, like these kids when they're really young are hard to miss, right? They're like, ding, 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 ding. They're under the table. It looks like it snowed in the room when you walk in because the exam paper has already been shredded. You know, like these kids you identify when they're young, and typically they will look better as they get older. Those symptoms do lessen. But you know, it can be those kids who are a little older or who have a little less severe symptoms who really just sitting in a chair is too much for them. Like they can stand at their desk, but they can't sit. It's just it's physically difficult for them. When we do what looks like hyperactivity in kids with autism and anxiety, also in autism, sometimes it can be related to developmental delay. Certainly kids who are delayed will be more like a kid of their developmental age as opposed to a child who is their chronologic age. So if you have a 5-year-old who is functioning more like a 2.5-year-old, their activity level is going to be like a toddler. And so you can imagine how well that probably works in a kindergarten classroom. Sometimes these kids aren't identified before they have, in some skills, kindergarten more than one. So, you know, it's important to kind of be paying attention to, you know, could this be a developmental issue? Is this kid just not understanding because they're not ready yet for what the expectations are? Also with autism, so it's difficult for them to understand the appropriate behavior in a certain situation, so it's hard for them to, you know, read the cues, like, okay, we're in a lecture hall now, someone's up at the front talking, I need to sit, I need to listen, and unless you give them specific instructions, it's hard for them to manage those cues, so they can look very hyperactive because they have trouble understanding the cues in different situations. If you think about it, the cues change very quickly from situation to situation, so it's hard, some are great at this, but it's hard to give them, especially an undiagnosed child, enough instruction for each situation for how to behave. What I'll talk about on this slide is kids with anxiety. So I have a lot of kids who I see who were previously diagnosed with ADHD, or they get referred for a question of ADHD because they have this hyperactivity piece, but really what it is it's either kind of fidgety nervous movements or they're hypervigilant. So these are the kids who they're sitting there and they're just kind of constantly looking around, checking what's going, what's happening next. Do I need to be worried about anything? And those kids can look very fidgety and very uncomfortable in class. And really they have, when you talk to them, or I have some kids who aren't able to explain it yet, but you can kind of see a qualitative difference in the room once you start looking for it. This kid just really needs to move versus this kid is hyper attentive to things and is vigilant, and it has an anxious kind of quality to their movement. I wish I had videos of this. I looked very, very hard for YouTube videos of this, and I mostly just found a bunch of kids having tantrums, which I didn't think was going to be really helpful for talk today. But if anyone knows of some, I would love to see them. I don't know. I thought about trying to set up my own kids and videoing them, but I didn't think that could persuade them to act quite the right way that I needed for the video. So once again, for people who think about things differently, this is the same information as the previous slide, just kind of presented a different way for your reference at home. I'm not going to spend a lot of time on the DSM criteria. This is kind of the basics of ADHD diagnosis. So when we're looking at diagnosing ADHD, we're looking at kids to have 6 or more symptoms from either the inattention or the impulsive hyperactivity group. So if they have 6 screening symptoms in one category, we don't need anything in the other category. That's very, very unusual. Usually there's a mix of both, and one is a little bit more dominant than the other. Boys tend to be, especially at younger ages, tend to be more predominantly hyperactive, impulsive, whereas girls tend to be much more inattentive. You can imagine kind of in gender stereotypes how that may play out. And I think for that reason, a lot of girls tend to get missed. The use of making an ADHD diagnosis is the symptoms had to be present and causing impairment before the patient was 12. It used to be 7 in DSM-5. They changed it because they've want most adults who are presenting with ADHD symptoms are going to have a really hard time remembering what academic work was like in 2nd grade, but they might have a chance of remembering 5th, 6th, or 7th grade. The impairment has to be present in at least 2 settings. Places where I think sometimes I get tripped up with this is that the parents who are extremely attentive and really wonderful at meeting all of their child's needs, they have 0 problems at home, it's just at school. But when you ask a few more questions, you find out that this kid cannot go to a neighbor's house, he cannot go to a birthday party, he cannot go anywhere without getting in trouble. And that the parents have scaffolded him beautifully. I keep saying him because most ADHD patients are boys, but I shouldn't do that. Scaffolded him beautifully at home, and but they can't take him anywhere else because he needs that much support to function. The other thing, so the impairment must be clinically significant. So, if you just feel like if you have one of those kids who's like, I feel like I have trouble paying attention, I feel like I could do better, that's not enough. We have to have some sort of more objective data that they're struggling. I'm not going to talk about this today, but that kind of gets into that issue with adolescents who may be presenting with complaints about ADHD but really want medication because they are going to use it to cram or they are going to use it to for other purposes, try and get some improve their academic performance. ADHD medication. The other area is just kind of the standard DSM caveat. So, you're not only having, did you have a question? Oh, okay. So you're only having ADHD symptoms while you're psychotic, right? That if you only have ADHD symptoms while you're psychotic, your diagnosis is psychosis. It is not ADHD. They did get rid of, so they used to say that autism was an exclusionary diagnosis, and they did change that in DSM-5. So a few screening tools to talk about. So I'm going to talk a little about the Vanderbilt in depth because I think that's probably the most commonly used screening form in pediatrics. Does anyone here use the Vanderbilt? Does anyone use any other screening tool? Otherwise, you yeah. Certainly an issue for some people. I think not in primary care, so I'm not the best person to answer that question. I do think that sometimes it's unclear. We do have, at least in our clinic, we have a special set up with the Rainbow Primary Care Clinic to send a chance where it's unclear and there may be some complicating comorbidities. So, definitely a reason we get kids, but I don't know if that's there's definitely some people who are kind of uncomfortable with just the whole mess that is sometimes ADHD.
Another one we are starting to use the child behavior checklist.
Okay. Yeah, that's actually the Achenbach. That's another name for the Achenbach. It's formerly the Achenbach. I can't remember what, but the child behavior checklist. It has the green and the blue forms. Yes. So I really like that one. But so to these forms. So the Vanderbilt is wonderful. You can print it for free off the internet. Those are, it does kind of screens for comorbidities. It's in the AAP toolkits. A lot of, really things about the Vanderbilt, but it is not your most sensitive or specific tool for ADHD. So in some studies, like the positive predictive value of the ADHD scales is like 0.18. So like not helpful if it's negative, so helpful if it's positive. We have to kind of really think about, okay, what do these symptoms mean? 3, you pay for it's one of those it's a red triplicate form. Anyone's using that? I use it very often in our office either because it's expensive, but when I'm having a really challenging situation, I like to use it because it actually has subscales on there to help you figure out if the parent or teacher is over or under reporting symptoms. And that, a lot of times you see those situations, you kind of have in your gut that that's probably what's going on, but it's nice to kind of document it a little bit, especially if you're pushed to make or not make a diagnosis that someone realizes is a problem. Okay, close me up. Other rating scales are the ADHD rating scale, which is very so it's really similarly to the Vanderbilt, so it kind of goes through the criteria. It's shorter than the Vanderbilt. It doesn't have as much much in the way of other disorders. ASRS is also similar to that. The CBCL or the Achenbach, which was mentioned before, so there is a very long screener, but it's a very broad behavioral screener. It can give you a good idea of what symptom clusters, if not what other diagnoses are present. Kind of the downside of the Achenbach is it doesn't go through all of the ADHD criteria. So it has many of the criteria on there, but not all of them. It's not quite as expensive as the Connors 3. I asked and I missed, I apologize, whether there's a link between ADHD and mental illness. So a lot of from that slide that we had with all the coexisting conditions, so there's definitely, with conditions we listed, there's a lot of crossover as far as psychotic episodes or schizophrenia. There's not as much overlap there. There's more overlap with autism. The other thing that I think comes up a lot is bipolar disorder. So that's actually very tricky to differentiate from ADHD, especially in young children. It seems like a lot of kids who go on to develop true bipolar disorder as adolescents have ADHD-type symptoms when they're younger. And there is some evidence that there are kids who do have both. We'll talk a little bit about that as we move through here. So talk about the Vanderbilt for a couple minutes. So it's divided up into different symptom criteria. So all these criteria on the Vanderbilt come right out of the DSM. The first 9 questions are the inattentive criteria. The next 9 questions are the hyperactive impulsive criteria. Then there's the ODD criteria on the parent form. Then it's followed by the conduct criteria, conduct disorder criteria, and then the anxiety and depression symptoms. The and oppositional defiant disorder scales are combined on the teacher form. So if you notice that the teacher form is a little bit shorter, that's why. The teacher may not have knowledge of all of the things that would go into a conduct disorder diagnosis, so those questions are not in there. So just to think about the ODD symptoms at the bottom. So many kids with ADHD, with untreated ADHD or untreated anxiety for that matter, will have a lot of oppositional defiant symptoms. And ADHD kids, it's more related to impulsivity. So their first impulse is to say, no, I don't want to do that. And so that they say or do, and it's much easier not to back down from that once you said it than to say, like, no, I really meant I would do it. I'm going to go do it. So once you help them calm that impulsivity a little bit, usually the ODD symptoms go away. With anxiety, you see a lot of ODD symptoms because kids may be afraid of something that you don't know about. To borrow an example from another case you're talking about in our clinic this week, a kid who's really afraid of dogs. And, you need to take them somewhere, but the last time you were there, they saw a dog. And they don't tell you that that's why they don't want to go. Maybe they're a little bit embarrassed about it. So I'm not going to say that they're just going to throw a huge fit about going to the grocery store, to the neighbor's house, to wherever the place was that they saw this dog. And so until you pick that apart and figure out that really that's what's caused them to refuse to do things, that there's this association with these fears that they have, they can look very like they have ODD. So I find for most of my patients, especially young patients, the conduct disorder symptoms are helpful for telling me which parents are totally stressed out and just circled threes all the way down the form. So, sometimes it's my indicator for like, okay, this parent is just really stressed out. They didn't really read my form. Their 6-year-old has not forced someone into sex activity. They have not attacked someone with a weapon. They have not deliberately set fires to cause harm. They didn't read any of the questions in this section. They are just really, really stressed out and overwhelmed by what they're dealing with this child, and they just circled a bunch of threes on my form. So just, that all those questions are in there in the conduct disorder symptom criteria. And so if you have particularly a young child who's really unlikely just by virtue of being a 6-year-old child, the parent is endorsing those symptoms that can help you help parent kind of the child a little bit so you can get a more accurate reporting of their symptoms. On the next section, the anxiety depression symptoms are really to be very insensitive. There are some authors who've looked at it and suggest that using a lower cutoff may be helpful for this section than is suggested in the Vanderbilt scoring. I see clinical symptoms first before parents rate symptoms on the Vanderbilt, and if I give them an anxiety screener, they may come up on the CBCL, but I'm not seeing anxiety and depression symptoms come up on the Vanderbilt before I see them clinically. Any questions before we move on? Yes. Great question. So the question is, how do we do an ADHD evaluation in the summer when we're not able to get Vanderbilt screens from the teachers? So that is a little bit complicated. In school-age children, I try and hold off on medication until I have documentation from the school. We don't get a lot of school-age children coming into our office during the summer. That may be different in your practices, but you huge bubble of new ADHD diagnoses is in the fall. For young children, sometimes you can get them from a secondary caregiver. So, if they spend all day with grandma when mom's at work, if they spend, if they're in a child care setting, that can be your second setting. Even for a school-age kid who's maybe at camp or something, and you really feel like this kid is struggling and needs some help, that can be your second setting. But I've been fooled many times by a really good story for ADHD that turns out to be something else. I just had it a couple of weeks ago who looked in the visit like anxiety. Mom and dad really didn't report any anxiety, just reported ADHD symptoms. The school kind of didn't report much either way. And so, we did a trial of ADHD medication, and he started having panic attacks. So, to trying to, risk benefit, going to help here, but this family was really struggling, and it was really difficult, despite what I was seeing in the visit, to get corroboration from anywhere of what I thought was going on. And it turned out that probably I should have kept pushing anxiety diagnosis rather than doing a trial stimulant. But hindsight is 20/20. So that probably happened to you too sometimes. But if it doesn't, it happens to all of us. I think ADHD is a lot more in people's consciousness than anxiety is for sure. That's your question. Before we move on to talking about using medication. So when you think about ADHD medications, you can think of them in a couple broad categories. So we spend most of our time talking about stimulants. So those are the amphetamine salts, so that would be like alcohol, Vyvanse, those are all the amphetamine salts. Methylphenidates would be Ritalin, Concerta, Metadate, those are all methylphenidates. And they have very, very similar mechanisms. There are some suggestions in the literature that the amphetamine sulfa may be a little bit more specific to dopamine than the methylphenidates, but that doesn't always play out clearly. Non-stimulants, so guanfacine, clonidine, and atomoxetine. Clonidine and guanfacine are both alpha agonists. Have a totally different mechanism than the stimulants. And then atomoxetine is actually an SNRI. It was originally as an antidepressant, and it was a kind of terrible antidepressant, but seemed to improve anxiety a little bit and ADHD a little bit, so that's how it's currently marketed. This is just my personal experience, but my personal experience with atomoxetine or Strattera is that I use it as kind of a last resort because I tend to have a lot more side effects than I have symptom control with atomoxetine. So with stimulants, and you're trying to figure out, what I should be using, is this going to be helpful? So if you have correctly diagnosed ADHD, about 70-90% of children should respond. So these are from samples of children referred to child and adolescent psychiatrists, so likely to have an accurate diagnosis. In most of these studies, they let the psychiatrists try 3 or 4 different stimulant medications before they decided that it was a stimulant failure. Some kids, for reasons that we don't quite understand yet, which probably have to do with how their body specifically processes the different medications. That's how their stomach acid works on the extended release formulation, or how how it's crossed their blood-brain barrier, or the posynaptic receptors that inhibit, or the presynaptic receptors that inhibit the reuptake. Have all these things sorted out yet. So some kids really do respond better and worse to different formulations, and we don't have a great explanation for that. The mechanism, we think, to the best of our understanding, which there's still a little bit of discussion about in the world of ADHD treatment, so stimulants block reuptake of catecholamines, making them more available to interact with the postsynaptic neurons, and the thought is that the prefrontal cortex is particularly sensitive to this, and that's why you get this effective improved attention and impulse control. I also say that methylphenidate in particular is very similar to caffeine. So if you think, I think, for explaining this to parents who are coffee drinkers, sometimes we can kind of explain this like coffee in reverse. So a little bit about side effects. I'll talk a little bit about that. In IMC patients, we typically start with a very small dose of short-acting, titrate up to what dose we think we're going to need, and then by the number of milligrams we have throughout the day, convert that over to a long-acting dose. You don't need to do that in care practice where you have a fairly clear-cut case of ADHD, especially if it's the second or third child in the family with fairly clear-cut ADHD. It's probably reasonable to put them on medication that their siblings have been on that's very likely to be effective. But I have a very high comorbid population who do not necessarily respond as well to stimulants, so we tend to go very, very, very slowly. And to go wrong with that approach, it just takes a lot more time to get up to what's going to be an effective dose. So one of the other pitfalls of using medication in ADHD is I think people think in their minds when you're saying, okay, I'm going to give you medication for ADHD, that the ADHD medication is going to make all of the badness go away. And that is not how these medications work, unfortunately. They are really good, but they are not magic. So it doesn't treat or cure the ADHD. The child is still going to have this immature or slightly dysfunctional prefrontal cortex. It's just that, the way that they're put together. But the medication will make the symptoms go away while the medication is active in their system. So some analogies you can fit this are like wearing glasses. So if you put your glasses on, you can see a lot better. But the second it doesn't change your eyes at all. The second you take them off, you don't see as well. And I think especially because ADHD medications and stimulants in particular have a very short half-life, and they're in and out of your system within the day. I think that's a helpful analogy for people. Some people talk about it like taking insulin for diabetes. I think, in some ways a better metaphor for the consequence down the line of not using treatment. But it breaks down in other places. You're not going to die of anything. Well, you are immediately going to die of something if you don't take your ADHD medication. The medication doesn't change the behavior. So if you have a child who has not, they've had this ADHD and they have not been in an environment that's been able to cope with that, where they have not been able to learn appropriate social skills, or they've not been able to learn how to manage themselves when they get frustrated, this isn't going to fix any of that. They still need some sort of behavioral intervention that's going to help support them through those situations where they can learn those skills that they need. One of the psychiatrists likes to say the medication unlock file cabinet, but you still have to put things in it. So the next thing to think about with medication is using short-acting versus long-acting medication. So medication is in and out really quick, 4 to 6 hours usually. It peaks at 2 hours, and you have to give it at least twice a day for most kids to get them through the school day. When I'm starting medication, I usually put kids on it just in the morning, because that gives us a nice way to see, is morning behavior really different than afternoon behavior, where it wasn't before? And then if I cause any nasty side effects, we're only going to have them for 4 hours as opposed to having them for 12 hours. The other short-acting is for kids who have trouble taking pills, but we need to really carefully titrate their medication for some reason. You can do it with the crushing the medication. We'll talk a little bit later about getting kids to take medication, but I find that very useful for the just methylphenidate and amphetamine salts. The long-acting, so it usually lasts 8 to 12 hours. There's some newer formulations coming up that actually last much longer, and they're actually working on a new drug that is supposed to be out sometime next year or so that you can actually take the night before, and it delays the release for 8 hours or so, and then it has I think a biphasic release the next day. Usually when you're converting over from short-acting to long-acting, you just add up your doses through the day, and that gives you an approximate place to start for your long-acting dose. So I here listed all the different formulations of short-acting methylphenidate. So you'll notice that Focalin is actually dexmethylphenidate, so it's the D isomer. How much time any of you spend treating asthma, but it's similar to the relationship between albuterol and levoalbuterol. So dexmethylphenidate definitely has its stand there, and there's definitely a few kids I have who seem to respond better to it with less side effects, but for kids they're about the same. Methylphenidate, so you'll see on this slide it's a little bit more complicated. There's a lot more medications listed, and there are these numbers next to each of them. What those numbers indicate is how much of the medication is released immediately and then later on when you take it. Serta is you get 22% of the medication initially, and then about 6 hours later you get 78% of it. Focalin and Ritalin is 50-50, so it's half. They're capsules with little. Half of the beads inside are enteric coated, half of them aren't. So half of them you get immediately, and half of them, depending on how your symptom works, you'll get about 4 to 6 hours later. Patch formulation available and chewable. The Quillavent and Quilichew is not really available right now. There's been a lot of manufacturing problems. So another way to think about this, I think this slide helps to illustrate what is these different release patterns. So if you have kids with different needs, so you have a kid who needs to get through the access at the end of the day, you might pick the green line, which is concerned that's lit up front, and then more later in the day. They still have medication in their system 10 hours later that will get them through whatever evening activity they have. If who isn't eating well, you might want to switch to short-acting. If you see the yellow line, so that's 2 doses of just regular old methylphenidate. And there's that lovely little valley in the middle, which if you set your medication up right, can coincide nicely with their lunchtime. And so hopefully they will eat a little bit more at lunch. and we won't have as many problems with weight as we would otherwise. I see some kids, so this hasn't been as well established, but I do have some kids who tend to have more intense appetite suppression with the short-acting and then have this kind of rebound voracious hunger afterwards. And so some of those kids I actually find do better on a long-acting formulation than on the short-acting formulation because they eat a little bit more evenly through the day. So this is a European study. That's the trade name for what is Metadate. Here in the U.S. it's the 3070 release. You can see, kind of see what that looks like in the bloodstream, the kind of coverage you might have for that. And then in LA is the 50-50. So you can see bump, kind of a tiny drop down and then another bump again later. So depending on the different formulations of these different medications, you can kind of play with the middle part of, what does your day look like? You're a morning person, you don't really need this much in the morning, or it's, maybe it's too much for you in the morning. And so you can kind of adjust which formulation you're using to try and meet all of those needs. Amphetamine salts are very much analogous to the methylphenidate, so they're short-acting and long-acting, and there's not as much variability in the release patterns in the amphetamine salts. Otherwise, it's very, very similar. So if you're writing for generic, you just write mixed amphetamine salts on prescription, which to this day I feel like a drug dealer when I do that, but that is how you write it. And then there's all these different brands available. There's also a liquid the liquid is newer and I have not used that much, so I don't have much experience to share with you on that. There's also a bunch of different acting amphetamine salts. So there's an oral dissolving tablet which came out recently. You can see that a lot of these are 50 formulations. It's different in that it's a prodrug. It's still a controlled substance. It is, the initial thought was that it was a little harder to misuse or abuse. You can't open it up and snort it because there's lysine molecule attached to the dexamphetamine molecule, which is supposed to be leaved off in the bloodstream. That hasn't panned out quite as well as people were expecting. But the one thing I will say about Vyvanse is there are some kids who appear to be unable to cleave that molecule off, and so you give them Vyvanse and you might as well have been giving them water. It does nothing. And so if you're a person who tends to start with Vyvanse, if you have a kid who just doesn't respond, it doesn't necessarily mean that they don't have ADHD or that their ADHD is particularly hard to treat. It probably just means that they aren't able to cleave that molecule off to the active form. There's a newer liquid formulation of long-acting amphetamine salts. It doesn't have that same kind of clear release pattern that a lot of the long-acting ones do, but it kind of slowly peaks over 4 to 5 hours and then kind of slowly wears off. This a new formulation, Mydeas, which is a 3-phase release as opposed to a phase release. Similar to dexmethylphenidate, there's also dexamphetamine. In the GBPs world, we don't tend to use it because it seems like you get a few more side effects with that than you do with any of the other formulations. So any questions using and starting medication before we talk about kind of risks of using medication?
Medication you usually start with, I mean, it seems like there's so many different ways to go into the combo. If you're at some time,
I usually start with, because we're always starting low and going very slowly because of the population we see, I usually start with just straight up short-acting methylphenidate. Titrate that. If that seems to not be helping at all, I'd try short-acting amphetamine salt next and take that and see where we go. And then from there, if we're getting some effect but not good, then I might move to focal. But that's my typical pattern, and that's just me. That's not. There's a path in the literature. The literature, if you look at any of the guidelines in the literature, they'll say start a stimulant medication. Necessarily say short-acting or long-acting. So there are some more specific guidelines coming out for more complicated ADHD from the Society for Developmental Behavioral Pediatrics. Those should be out hopefully in the fall. But I expect it to. So, but those should hopefully have a little bit more guidance for some of those tricky situations. Okay, so just to tell a few rumors before we stop talking about ADHD. So I heard the end of Dr. Shivapour's discussion. You guys were talking about EKGs in sports. So there's also kind of this issue going around in ADHD, especially with some very publicized cases of athletes who had died while doing their sport, who were taking stimulant medications. So this kind of led to this whole concern that everybody who was going to take stimulant medication needed to have an EKG. So the short answer is they don't. The official policy from the AAP is that it's important to take a thorough family history and do a physical. They actually have 14 questions that they recommend that you ask. So it's, like, has child ever had syncope exercise? Have they ever fainted with exercise? Have they ever reported palpitations? Have they ever had any kind of cardiac event? Do they have any kind of malformation? Are there any? There's a whole host of things. Any sudden deaths in the family? But I have a questionnaire that I put together all those questions on it that I give to people. But I also ask them, I say, has anyone in your family died unexpectedly before 50, to try and screen out any kind of major heart issue. I tend to send people that have kind of unclear family histories to cardiology to have them evaluate, is there anything going on with this child that should make us concerned. This is most kind of common if you think about it. So reasons to use stimulants, or at least hold off while things calm down. So if you are increasing catecholamines, anything that is negatively affected by increasing catecholamines is going to be a problem if you add a stimulant. So kids who are hypertensive, hyperthyroid, hypoglycemia, who have been on an MAOI. So we have structural cardiac problems because there's concern for disruption of that electrical system. Then there's not a lot of data in pregnancy or breastfeeding. Some of the animal data is a little bit concerning, but there are no human studies. So generally the recommendation is, unless it's a safety issue for mom, that we not use stimulants in pregnancy or breastfeeding. And then the other reason is if you suspect bipolar disorder. So as we mentioned before, this is really tricky to sort out, especially in young children. If you have clear evidence of mania, that that would be a reason to suspect bipolar disorder, but most kids do not present with obvious episodes of mania. In my practice, usually what I do is I ask for family history to kind of guide me. I know in adults, bipolar kind of gets thrown around a lot. So I usually ask, so, you said Aunt so-and-so, bipolar disorder, what did she do for bipolar disorder? And then I kind of say, well, it's probably not bipolar disorder. If they, well, she was taking, she was, if they took an atypical antipsychotic, or she was on lithium, or she'd been hospitalized for it, then I take that family history a little more seriously. I think. And then also, no, this is in the wrong spot. Sorry about that. So if just for reference, this is kind of algorithm for who needs for the cardiac workup ahead of starting a stimulant medication. A little bit about how to get kids to take medication. So all of the original FDA trials of ADHD medication were in an empty stomach. So some pharmacies will still put that little label on it that says do not take with food. There have been subsequent studies that show that the absorption is not substantially affected by food. So I actually write most of my prescriptions to say take with breakfast and with lunch, because you can avoid a lot of stomach aches and a lot of the appetite suppression if you actually have kids eat something, get something in their stomach before they take their medication. You can't do about the lunch appetite suppression, but you can at least get them started something in their stomach. There's always the liquid, chewable, or patch formulations. You can crush the short acting. So I tell families is just you can crush it between two spoons. and then put something desirable on the spoon. In patients in particular, I'm a strong advocate of taking medication with junk food for the purpose of a lot of my patients, once they discover there's medication hidden in their food, will refuse to eat it forever and ever, so they will no longer eat applesauce or yogurt or other various healthy things that we may want them to eat. So I pick something, don't care if they stop eating. So, chocolate syrup, strawberry syrup, I am fine with all of those. You should still be eating something else for breakfast, but if you have to put it in that to get them to take it, I am okay with that. Oreos are actually excellent for kids who have problems with the texture. You can, smash it into the cream, put the cookie back on top, hides the taste, hides the texture, works very well. But I'm also typically dealing with a population of kids who are a little bit more resistant to taking medication than average. So, but those are some of my tricks. And about medication before we very briefly talk about side effects, because I know we're running to the end of our conference here. All right. We'll briefly talk about managing medication side effects before we wrap up. So we're trying to sort through side effects of ADHD medication, or specifically stimulant medication. The real effects of the medication you're going to see an hour or two after they take the dose, because that's when their blood level is highest. The quote-unquote side effects that occur after they take it are either the ADHD symptoms coming back. Some kids tend to have this sort of like or moody period as their medication is wearing off. I also have some kids who are very sensitive to how the medication makes them feel and how they feel when they're on their medication and not on their medication, and so those kids will kind of have a little bit of difficulty with that wearing off period as well. So the most common side effects are decreased appetite, sleep problems, transient headaches and stomach aches when you start the medication, and then this behavioral rebound or irritability when the medication wears off. Two things for dealing with appetite suppression. So it is okay to give the medication with food. You can have the kids their medication after breakfast. Some kids will be a little bit hungry through the day, so trying to give definitely, particularly for younger children, can be helpful. You can consider switching to short-acting medications to take advantage of that valley that we saw in the graph of the different blood levels. So sometimes you can line it up with lunch. Kids might eat a little bit more lunch. You can take holidays from meds. This is a little bit controversial. People feel like that may actually center your growth more, but there's no evidence for this at that point. There's no evidence for that at this point. And then the other thing I tell families is especially if they're on long-acting medication, they're not eating dinner at night when I start the medication, like that's my fault. It is not their fault. Please let them eat something later. They are not, they're not eating because I put them on medication. They're not eating because they're trying to be a difficult kid. Headaches and stomach aches typically resolve on their own in 2 weeks. These tend to be, in the literature, they tend to be reported as common. I don't see them very often, but in kids where I see them, I tend to see them recur every time we increase the dose. So we have, a brief period where we have headaches the first 3 days of the new dose every time. Problems, so when we've drilled down on this a little bit, most sleep problems related to ADHD medication are actually sleep hygiene. Really kind of try and sort out the sleep hygiene as much as you can before you mess too much with the medication or stop the medication because of sleep problems. If you really do think it's medication, you can decrease or eliminate the afternoon dose. Particularly if you have an older kid who is on like a 3:30 or 4 o'clock little boost dose in the afternoon to help with whatever school activities they might be doing, can you get rid of that? Can you give it a little bit earlier? I had a few kids like in junior high where we moved their morning dose a little earlier and actually had the school give that afternoon dose before they left for the day, and that's worked out well for them. You can just move all the doses earlier in the day. So if we were doing 8, noon, and 4, can we do 7, 11, and 3 instead? And then really sort out their caffeine consumption history, because I've had a lot of kids. The most extreme example being this family where Mountain Dew was a drink of choice, and they just kind of left it out on the coffee table for anyone to drink at any time, night, whenever. So you can imagine that was causing a lot of sleep problems. And one final example, so I had a kid who's, it was cold out, started drinking hot chocolate every night before he went to bed, and then was having trouble sleeping. We got rid of the hot chocolate, and he started sleeping just fine. So I think the stickiest side effect tends to be this behavior rebounding irritability. Looking at those curves, you have the slides in front of you. You can flip back real quick. But with the long-acting medication, you tend to have this more gentle carrying off of the medication. There's a much more gentle slope than the on-off of the short-acting. So sometimes with that kind of longer, slower wearing off period, kids have a little bit less of the symptom. You could also consider adding a tiny afternoon dose, somewhere in the range of like 2.5 to 5 milligrams of whichever, either an amine salt or a methylphenidate, whichever you're using, to kind of draw out that that wearing off period. I also have families who just structure the day so that this hour of medication wearing off doesn't get the kid in trouble. I have one patient where like it's his special Lego time. His sister is not allowed to interrupt him. Like that's what they do. That works for them. But it takes a higher functioning family to pull off. Some may be hungry because they haven't eaten well enough. I think this is actually one of the more common things that I can fix. I would say maybe 10 to 15% of kids who have this afternoon issue that we can get rid of it by getting them something to eat when they walk in the door from school. The other anecdotal share in this regard is I had one patient who was very sensitive to being on and off his medication, and when he was about 8, he told me that he could feel his medication wear off, and it felt like his brain was getting messy again, and that really bothered him. And so that was a really tough period for his day. And so I explain that sometimes to parents. So here's my coffee analogy. So if you're a coffee drinker, you kind of have that like fuzzy feeling in the morning before you've had your coffee. You drink your coffee, you're ready to go. So the stimulant is kind of similar to that. And when it's wearing off in the evening, it's the reverse of that. So, that fuzzy feeling, you can feel that fuzzy feeling kind of creeping on again as your medication is wearing off. For some kids, that feels really uncomfortable. And so I think explaining it to parents that way can be a helpful way to address that issue for their child. So we've talked through all of that complicated stuff about treating ADHD. Why are we bothering to do this if the diagnosis and the treatment can be so complicated? And really there is evidence that there's increased risk of drug and alcohol use and experimentation in kids with untreated ADHD. There is risk of grade retention and failure to graduate from secondary school, and that's not just the U.S., it's in the big European cohorts also. Increased risk of juvenile justice involvement and increased risk of injuries, particularly car crashes in teens who are driving. So if anyone has any questions, please feel free to ask them. Yes. Mm-hmm. I think that we have a clear, we can't say like if you're going to grow out of your system, symptoms are going to grow out of them by 18 or 26. I don't think we have, that is still really, really kind of fuzzy. So that's a good question. I wish I knew the answer to that. Any other questions? Yes.
Now, what are the age groups that you start using your methylphenidate on? What do you feel about that early?
So this is where we get into the slightly off-label part of the conversation. So I tend to start with methylphenidate regardless, because I feel like my experience is that you can fine-tune that dose a little bit better. But you're correct; it doesn't have labeling until age 6, most of them. But the Adderall does have labeling down to age 3. And like many areas of psychopharmacology in kids, I don't really understand why the labeling is the way it is. It doesn't exactly fit clinical practice, and when we will get some guidance on that in the near future as to what kind of clinical practice dictates as opposed to just the labeling. But that is what I tend to do, and I think what many of my colleagues, at least at Rainbow, do would be to start with methylphenidate, even though as a labeling. So for young, so the recommendation from the AAP is for young kids to start with behavioral interventions, so the preschool age group. For older kids, they recommend to start, you can see either one. Really, so when we were talking about, like you have to fill the file cabinet, the medication is not a magic pill, it's not going to make everything go away. That really most kids need some sort of, some sort of behavioral intervention, whether it's, it's more traditional psychotherapy, whether it's something, whether it's CBT, whether it's, there's actually versions of ABA that work really well for ADHD. That most kids benefit from behavioral interventions. I do, and I feel like I kind of use it as I use it for sleep. A lot of different kids, the sleep gets really complicated, and we could spend like another 2 hours talking about all the sleep issues in kids with developmental disabilities. But I think the tricky thing is to really sort out the sleep hygiene issues first before you go to clonidine. I also use it as an adjunct, particularly for kids who have a lot of really disruptive, hyperactive behavior. Check typing questions that I missed. Thank you.
Thank you. Great. Oh, I guess I'll turn the lights on. Our absolutely wonderful speakers. I know how much you guys work and how busy you are. I cannot thank you enough for making this day great. I'd also like to thank our vendors for their support. And make sure you guys fill out your evaluation forms that are in your folder. Hand them in at the registration table to Randy and Brandy. There's a blue box and a yellow box. You can just stick them in there. And when you hand in your evaluation, you can get your CE certificate. If you need parking, just ask them. Have the brochures there too. Okay? Thank you guys for coming.